1960s, Stanford University pioneers heart transplantation research. 1967, Dr. Adrian Kantrowitz performed the first pediatric heart transplant. Unfortunately, the infant survived only hours. 1970s, cyclosporin development marks a breakthrough in immunosuppression. Bailey and colleagues at Loma Linda transplanted a baboon heart into a newborn infant, baby Faye, with hypoplastic left heart syndrome on October 26, 1984. The baby survived 20 days. 1983 International Society of Heart and Lung Transplantation establishes a registry for tracking transplant data globally. Over time, techniques and outcomes have evolved significantly. Current landscape: transplants performed globally, 117 centers worldwide. Variability in frequency less than 4 to 10 transplants annually. From 2010 to 2018, 45.5% of transplants occurred in centers averaging more than 10 years. Advanced centers contribute significantly to survival improvements. Recipient data: age distribution, peak at less than 1 year, primarily congenital heart diseases. Then in adolescent, 14 to 17 years, mostly cardiomyopathies. Bar diagram showing the distribution by year of transplant. Over the year, the age group of 11 to 17 has increased. Listing to transplant. Factor influencing listing: age, size, blood type, CHT versus CM, and comorbidities. Congenital heart disease versus cardiomyopathies and comorbidities. Innovation: ABO incompatible hearts for infant without preformed antibodies. Ventricular assist devices reduced waitlist mortality. Challenges remain for infant and complex cases. Heart transplant techniques: biatrial technique, simplest but associated with atrial dysfunction and valve issues. Bicable technique, preferred due to reduced complications, require precise SVC, IVC anastomosis. Total heterotrophic transplantation, rare and highly complex, used in select scenarios. Impact of ventricular assist device: provide critical support before transplant, especially in dilated cardiomyopathy. Challenges include device removal during surgery and related complication. Improved survival rate for recipients on VAD support. Overview of challenges. First, small size and anatomical constraint. Secondly, scar tissues from previous surgeries. Third, technical challenges in anastomosis. Fourth, managing ischemic time and donor heart preservation. Fifth, hemodynamic instability. Small size and anatomy. Smaller chest cavity complicates fitting the donor heart. Delicate and small vascular structures increase suturing difficulty. Congenital heart defect often require additional reconstruction. Technical challenges in anastomosis: size mismatch between donor and recipient vessels, complex reconstructions, example pulmonary artery and coronary alignment, risk of stenosis or leak at anastomotic sites. Scar tissues from previous surgeries. Many pediatric patients have had prior surgeries for congenital heart disease. Scar tissue and adhesions complicate dissection. Increased risk of bleeding and prolonged surgical time. Ischemic time and preservation. Pediatric donors often located farther away, increasing ischemic time. Prolonged ischemic time can lead to graft dysfunction. Meticulous heart preservation techniques are crucial. Anatomic variability and single ventricle. Congenital heart defects present unique challenges: hypoplastic structures, complex prior surgeries, and scar tissues. Staged repairs, Norwood, Glenn, Fontaine, create significant variability. Fontaine patients often face the highest surgical complexity due to prior procedures. Donor evaluation and procurement. Donor consideration: age, heart size, blood type, and comorbidities. Collaborative approach, coordination between heart, lung, and liver teams for shared donor resources. Minimizing ischemic time, critical for improved survival, affected by travel, prior surgeries, and recipient anatomy. This is a chart showing the diseases which are mostly requiring heart transplantation. In less than 1 year, 56% because of congenital heart disease. Over the period of 1 to 5 years, cardiomyopathy is increasing, and as we approach the age of 11 to 17 years, 53% people are requiring, children are requiring because of cardiomyopathy. Transplant listing is on a case by case basis, but some of the common indications for cardiac transplantation are those listed. Refractory cardiogenic shock, heart failure requiring continuous IV inotropic or mechanical circulatory support, peak oxygen consumption of more than 14 ml per kg per minute without a beta blocker, or VO2 of more than 12 ml per kg per minute with a beta blocker, or VO2 50% predicted. Progressive deterioration of cardiac function or functional capacity despite maximal medical treatment, unacceptable quality of life, inability to perform daily activities, congenital heart disease unsuitable for surgical palliation or repair, malignant life threatening arrhythmias resistant to medical treatment, catheter ablation, surgery, or implantable cardioverter defibrillator. Progressive pulmonary hypertension that could potentially become a contraindication to heart transplantation in the future. Relative contraindication, irreversible elevation of pulmonary vascular resistance to more than 480 dynes per second centimeter, the upper normal limit less than 120, or a transpulmonary gradient of more than 15 mmHg, normal upper less than 12. Both presents a major risk for postoperative graft right ventricular failure. Active or recently diagnosed malignancy, major brain pathology with bad or uncertain neurological prognosis, severe progressive metabolic disorder with multi organ involvement, significant dysmorphism or genetic syndrome, severe irreversible end organ failure, pulmonary, renal, hepatic, or all three, small size, prematurity, major risk of drug non compliance, mental illness, drug, tobacco, or alcohol abuse, not applied to pediatrics. Severe active infection, HIV, chronic hepatitis B and C infection. Organ allocation in heart transplantation. Factors influencing allocation. Clinical urgency is a primary consideration. Additional factors include ABO blood group compatibility, size matching, sex matching, and human leukocyte antigen typing. ABO compatibility journal rule. ABO incompatible transplantation typically causes rejection due to immune activation. Anti-A and anti-B isohemagglutinin interact with incompatible blood group antigens, leading to graft thrombosis. In infant, blood group incompatible cardiac transplantation is safe in infants due to immature immune systems at birth, lack of isohemagglutinin production in the first year of life. ABA incompatible transplants are now standard practice for newborn. Equivalent outcomes have been reported between ABO compatible and incompatible transplants in small children. Requirements for success: reduction of isohemagglutinin titers before graft reperfusion, effective immunosuppression, and early treatment of antibody mediated rejection. Size matching, donor recipient weight ratio. Describe the weight difference between donor and recipient. Oversizing donor is common for recipient with dilated cardiomyopathy due to their enlarged mediastinal cavity. Extreme donor recipient weight ratio values less than 0.7 or 2 are avoided due to hemodynamic complication and delayed sternal closure. Sex matching impact. Increased mortality has been observed in sex mismatch transplant. Potential causes include immunological and hormonal factors, leading to a higher risk of rejection in the first year. Guideline: no specific recommendation for sex match transplant due to the risk of prolonged waiting time. Human leukocyte antigen matching sensitization. Circulating antibodies against HLA proteins increases rejection risk. Major risk factors: prior blood product transfusion, use of homograft tissues, mechanical cardiac support. Assessment: the goal is to minimize the risk of rejection and graft loss. Techniques: virtual cross match uses a panel reactive antibody test to evaluate risk. More than 10 PRA more than 10% indicates sensitized status. Variation in clinical practice reflect uncertainties in the significance of high PRA level. Management of anesthesia and cardiac transplantation. Pre-assessment for anesthesia. Pre-assessment should occur as soon as possible, often in the cardiac surgery or cardiology outpatients. Focus area include reviewing cardiac imaging, ensuring sufficient blood products are available, especially in sensitized patients, coordination with the donor site. Types of patient, we have patients on mechanical support. 30% of recipient, more than 50% of non-infants are transplanted from mechanical support device, most commonly ventricular assist devices. VATs can support the left heart, right heart, or both ventricles. Pulsatile devices, example Berlin heart, provide a pulse. Centrifugal devices, hardware offer continuous flow, and children with these devices may not have a palpable pulse. Outpatient management, children with hardware devices may be managed as outpatient. Extracorporeal life support used as a bridge to transplantation but not a long term option. Anesthesia consideration, patients on mechanical supports are often easier to anesthetize as their circulation is maintained. Anticoagulation is required to prevent thrombosis, which creates a challenges during the peri-transplant period. Patient without mechanical support, induction of anesthesia is high risk and must be performed cautiously. Anesthetic agents typically used include opioids, benzodiazepine, and intravenous or inhaled anesthetic agents. Patients without mechanical support often present with a wide spectrum of disease, influencing both anesthetic and surgical planning. A rescue plan is necessary in case of hemodynamic instability during anesthesia induction, including immediate access to cardiac surgeons and perfusionists, availability of peripheral cardiopulmonary bypass in case of cardiac arrest. Intraoperative management, central venous access, limited secure central access option may pose challenges. Long-term saline may already be present in place for inotropic support in heart failure patient at the ward or home level. Standard intraoperative monitoring include invasive arterial monitoring, near infrared spectroscopy, and transesophageal echocardiogram. Donor organ retrieval and implantation. Donor heart preparation, aortic cross clamp placement is followed by the delivery of cardioplegia solution. The donor heart is stored in cold preservative. The ex vivo perfusion system currently available for cardiac grafts. Transplantation procedure, cardiopulmonary bypass is established, the diseased heart is explanted, and the donor organ is tailored fit to the recipient. The reperfusion phase is the most unstable part of the operation and requires intensive hemodynamic management. Hemorrhage risk. Multiple sutures lined during transplantation increase the risk of hemorrhage. Preventive measures. Routine use of antifibrinolytic drugs like aprotinin or tranexamic acid if aprotinin is contraindicated. In NH, we use protamine. Management. Proactive transfusion of platelets, octoplast or cryoprecipitate or fibrinogen. Use of thromboelastography to guide the management of uncontrolled hemorrhage. Graft function and hemodynamics. Heart function, cardiac output depends on heart rate and stroke volume. The transplanted heart is denervated, which affects autonomic control. Biatrial anastomosis may retain the native sinoatrial node, potentially leaving two SA nodes. Bicable anastomosis remove the native SA node, relying solely on the donor's heart pacing. It is not uncommon to have complete heart block once aortic cross clamp removed. Sinus rhythm may return over time, but temporary dual chamber epicardial pacing is often needed initially. Long term pacing is rarely required. Stroke volume follows the Frank Starling relationship, dependent on preload contractility and afterload. Inotropic supports. Common drugs include milrinone, adrenaline, NORAD. Occasionally used drug isoprenaline and vaso. Pulmonary vascular resistance. Increased PVR from the primary disease may strain the right ventricle. The measures to reduce PVR are careful airway suctioning, ensuring lung expansion, and pharmacological aids like milrinone or inhaled nitric oxide at 20 ppm. Immunosuppression, induction therapy, initiated before graft reperfusion in more than 70% of the pediatric cases, reduces the incidence of acute cellular rejection, a common cause of early mortality. Common agents are anti-thymocyte globulin, increasing use of interleukin 2 receptor antagonists like basiliximab and high dose methylprednisolone. Maintenance therapy aim to balance host graft adaptation while minimizing infection and cancer risk. Typical regimen is calcineurin inhibitors, tacrolimus preferred in two-thirds of the cases, cell cycle inhibitor mycophenolate mofetil, or short-term oral steroid like prednisolone. Steroid remains crucial, especially in the first year post-transplant or during rejection episodes. Post-operative management, key complication, primary graft dysfunction, severe with high mortality in prolonged cases, right ventricular failure common in cases with pulmonary hypertension. Unique consideration lack of parasympathetic innervation requires external pacing or isoproterenol. Immunosuppression includes induction and maintenance phases requiring close monitoring. Post transplant complication, primary graft failure, presentation manifest as low cardiac output syndrome early post transplant. Causes prolonged graft ischemic time, poor graft preservation, hyperacute rejection, failure of the graft to adapt to the recipient's hemodynamic. Example right heart failure with elevated pulmonary vascular resistance. Treatment includes supportive care, occasionally requiring extracorporeal life support. Reported in 13.9% of cases, risk factors include long ischemic time and pre-transplant extracorporeal life support. Rejection types acute cellular rejection, T cell mediated, common in the first 6 months. Antibody mediated rejection, humoral response presents later. Hyperacute rejection, rare due to careful APO and HLA compatibility matching. Diagnosis gold standard is endomyocardial biopsy. Surveillance institution specific biopsy schedule start 2 weeks post transplant. Risk factor sensitization increases rejection risk, early episode worsens 10-year survival rate. Treatment depend upon the severity and clinical context. Treatment include steroids, immunoglobulins, plasmapheresis or photopheresis, anti-lymphocyte globulin, monoclonal antibodies, and immunosuppressive regimen adjustments. Cardiac allograft vasculopathy definition a chronic coronary artery disease in the transplanted organ emerging after 3 years, leading medium to long term cause of death. Management prevention induction immunosuppressive therapy reduces incidence. Diagnosis coronary angiography and intravascular ultrasound at routine interval. Treatments are limited. Retransplantation is the only effective option. To be noted, children may lack typical angina symptoms due to altered cardiac innervations. Additional morbidity infections, cytomegalovirus and Epstein-Barr virus are particularly concerning. Bacterial infections peak in the first month post-transplant. Prophylactic antiviral medication help mitigate risk. Malignancy, post-transplant lymphoproliferative disease, EBV driven due to reduced T cell activity. Common symptoms are upper airway obstruction. Treatment is reduced immunosuppression, chemotherapy, rituximab. All this point underscores the importance of tailored multidisciplinary care post-transplant to manage these complications effectively. Long-term outcomes, improvement in survival. Survival rates have improved in all age groups since the inception of the registry, with notable progress in infants. Age-specific survival, infants less than 1 year. Median survival after transplantation is now 22.3 years, significantly better than older children. Older children more than 11 years, median survival is 13.1 year. Paradox infants have the worst 1 year survival rate, but the longest overall median survival, suggesting that those who survive the critical first year may fare better long term. Diagnosis related outcomes. Patients with dilated cardiomyopathy have better 5 year survival compared to those with congenital heart disease or those undergoing retransplantation. Causes of death. Graft failure remains the leading cause of death shortly after transplantation. Chronic allograft vasculopathy becomes a prominent cause of death over time, sometimes affecting patients awaiting retransplantation. Adulthood risk. Medical non-compliance emerge as a significant risk factor for mortality as transplanted children transition into adulthood. So, Kaplan-Meier survival graph showing the over the years survival. The infant survival presented by the light blue line has increased over the year once they have crossed the 1 year rate. It dips around here, but then it continues to increase over the years. NH data, total 83 heart transplant done since 2008, out of which 23 are pediatric. First pediatric heart transplant was done in 2012 of a 15-year-old male child. Total in hospital mortality 15, out of which pediatric was 3. Recently we did the youngest heart transplant. Recipient was a 15-month-old child diagnosed to have restrictive cardiomyopathy at 1 year age. He had total hospital stay of 57 days, discharged in a stable condition. Till the recent follow-up, he has been doing fairly well. Well, NH protocol anesthesia, immunosuppressants given orally 2 hours before induction. At time of induction, methylprednisolone given. Right IJV spared for future purposes to do biopsy. After completion of procedure, TE done to look for gradient across the anastomotic sites as the level of aorta, pulmonary artery, and atrium. Intra-op, we mostly do bicable anastomosis. Post-op, if patient is all stable, extubated within 12 hours. Inotropes, adrenaline and milrinone are weaned over the period of 5 days. Immunosuppressants are given on the case basis decided by Dr. Sashira sir and the team. Thank you.
Well, Divyanshi, we made this comments earlier also. I am just curious to know, in the adults, we get most of the donors from RTAs or CVAs. What is the donor pool in the infants and pediatric patients, neonates and infants? Where do you get the donors from? What are the conditions where you get brain dead infants, and which you can use for heart transplants?
Sir, mostly what I've gone through and got to know, encephalic child or the child with the liver or the liver or the renal diseases which could not make up because of the failure. Heart is in the good condition, but most of them are the encephalic or hypoxic encephalopathic child.
So that is one thing, and second thing is comparatively the adult donor heart availability itself is scarce. So pediatric donors are even more rarer. So that is a major constraint for doing pediatric this thing transplants. I don't know the I have neither the knowledge nor the experience to do this. I'm sure Julius can talk about it. One important thing that I thought you should have mentioned is what is the actual difference between adult heart transplanting and the pediatric heart transplants? So, well, as regards to perfusion, as regards to myocardial protection, as regards to this thing, is there any difference or is it the same? I'm sure Julius may be able to.
Yeah, I think I'll answer that question because see, we have to look at pediatric transplants in two broad groups. One is the cardiomyopathy group, be it restrictive, arrhythmogenic, whatever it is, and the other one is the congenital heart disease group. So the ones with the congenital heart disease is a very different subset. The ones with cardiomyopathy is much like adult heart transplant in a smaller individual. In when you're doing transplants for congenital heart disease, it is required for you to make a very extensive preoperative planning as to how to make the connections. Suppose you have somebody with situs inversus, for example, the heart that you get is not going to be situs inversus, that will be situs solutus. So you have to figure out how you're going to make the various connections in that. And what I do is I do what is called a plumbing diagram and circulate it amongst the whole team so that even if I'm not there, everybody knows what the plan is. That is one aspect. And the specific point which Dr. Srikrishna brought out, the difference in the perfusion, that is a very important aspect because some of these children have got so much of collaterals. So when you're perfusing based on the formula of 2.2 or 2.4 liters per square meter body surface area, it won't reach anywhere because of the collaterals. The systemic circulation may be very poor. So until you can cool them, if you do not provide enough flow, you may end up with severe organ dysfunction post-operatively. We've had that problem once earlier. So what we now do, based on discussion with others and literature search, is to uh, do an MRI in all these children and figure out what is the systemic flow, what is the pulmonary blood flow, what is the collateral flow, and based on that we calculate what is the flow required uh, for that child during CPV. See, going by literature from circulatory support in terms of VADs or ECMO, etc., children with single ventricles with lots of collaterals have required up to an index of 8. I'm not talking about flow of 8 liters per square. Indexed flow of 8 liters per square meter have been shown to be required. So unless you calculate the flow appropriately, you will end up giving inadequate organ perfusion. See, now we have started to introduce the goal-directed perfusion in our unit. So if you are monitoring the adequacy of perfusion during the operation, you can adjust the flow according to that. We do a targeting of the tissue perfusion parameters. And all this started based on once upon a time we had a problem with perfusing a child who eventually died from all the organs other than the heart failing. So that was to answer your question. Once you're done, I have a few comments to make too.
Yeah, please go ahead.
Yeah. So I have expressed this to Divya earlier that both these papers are not high quality papers and probably not appropriate for a surgical forum. The one paper is published in the Pediatric Surgery Journal and written by a pediatrician and a pediatric surgeon. The other one, all the primary authors are anesthetists. So the focus is very different. And there are, because of these, there are a lot of factual errors in the manuscript. So they have, when Divyanshi's slide also said the 3 types of transplant. One is standard, one is total heterotopic is what she said. Heterotopic transplant is a completely different way of doing transplant. It is in heterotopic transplant, you will keep the native heart in place and the second heart is put as an additional pump. That is heterotopic transplant. In orthotopic transplant, the 3 techniques involved in orthotopic transplant are the standard one, where it is biatrial technique. The next one is bicaval technique. And I was telling her also, Giles Driffis is the one who came up with total transplant. The only difference in total transplant is the LA is also removed compared to the other ones. And you use the pulmonary vein cuffs for anastomosis. Giles Driffis was here in NH talking to all our PGs once before. But that has not become very popular at all. His point was to, like, when we compare standard heart transplant to bicaval transplant, the incidence of tricuspid regurgitation is less in bicaval because the atria is not stretched when you do the anastomosis. So he extended that concept to the left side also. That is why he came up with this idea of total heart transplant. I think there is a role for that particularly when you're doing these children with restrictive cardiomyopathy, where the atria can be extremely large and thick. I've had trouble doing biatrial anastomosis on such children. So if they're very non-compliant, thick atria, it might be worthwhile removing them and doing a total. Other than that, I don't really see a reason to do that. Particularly if it's very late in the disease, then the atria become as thick as ventricles, in a restrictive. Again, we spoke about size. Um, in children, we generally look at the height more than the weight. If you exceed 2.5 times the body weight, then the mortality goes up. Or if your body weight is much lower, also the mortality goes up. We must remember the length, that is the craniocaudal length of the heart also is important, because you cannot remove the SA node. So if it is too much of a length, also it cannot be accommodated. We worry more about the weight and heart size in single ventricle redo situation. So if somebody's had a Glen or a Fontaine before, and you're going to do a redo and it's single ventricle, usually the pericardial cavity is very small. At that time, you cannot put in a large heart into those children. But if it is a cardiomyopathy, usually the heart size is a lot larger, and then you can accommodate a much larger heart. The obvious problem which happens in these children is severe systemic hypertension postoperatively, which ends up with hyperperfusion of the brain and convulsions and all of that. So it is very common that you will need tons of SNP to bring the pressure down if you put a large heart into a small child. You also mentioned something about coronary alignment in when you're doing the transplant, which is irrelevant, because you're going to remove the native coronaries, and the coronary alignment in the donor heart is already there. You don't have to worry about that. Coronaries are what it is in a donor heart. In the recipient's heart, the coronaries are going to go away. So it is really not a relevant. So this is the problem when anesthetists and pediatricians write a paper on surgical issues.
True.
And ischemic time, normally we try and limit our ischemic time within 4 hours, but in children up to 6 hours is considered okay. So that is one of the difference. And you spoke of indications and peak oxygen consumption. See, peak oxygen consumption cannot be measured in smaller children, because you need to be on a exercise, bicycle or treadmill or something like that with a mask, in order to understand the peak oxygen consumption. And in the values which you told about 12 and 14 with and without beta blockers are relevant for only adults. In anyone under 18 years of age, it is 50% of what is predicted. That is the cutoff. And we do accept a higher PVR in children, and the value which you go by in PVR for children is the PVRI, which is indexed to the body surface area. And in adults, it is something which we worry about, more than 2.5 Wood units. In children, up to 9 Wood units of PVRI is considered acceptable, because a lot of times you're going to put larger hearts, and they will tolerate a higher amount of PVRI at that point. In the first indication that you said, it is cardiogenic shock. You do not take somebody for a transplant in cardiogenic shock. In cardiogenic shock, if you're looking at transplantation, you put them on a mechanical support of some sort. Then you assess their other organs, because a lot of times the liver is completely shocked before you get them. So if the liver doesn't recover, there is no point doing a transplant on them. We had a child last week where the liver just never got back to normal. The bilirubin remained high, and enzymes eventually come down even if the liver is completely destroyed. So it is important to take reasonably stable patients for transplant. You take somebody in bad shape, in cardiogenic shock for a transplant, your outcomes are not going to be good. Sex matching is not something which is relevant at all. I don't know where these people get their ideas from. See, in adults, what we do is use a formula called predicted heart mass. In predicted heart mass, you take sex also into account in the formula. When you put a female heart into a male, it may not work as well. It's not because of any difference in the genes or anything like that. It is just because of the size and the ability for it to function in a larger body mass. So that is the real thing. So in children, I don't think you would worry about it at all. And some amount of oversizing is acceptable in children. I don't know if I want to confuse you further with HLA matching, PRA, CPRA, etc. But these are things which are relevant for the West. We cannot do PRA or CPRA here because the reagents that they use to calculate the PRA are coming from the West. So if you have a PRA of more than 10, it means you might have hyperacute rejection with more than 10% of American hearts. It doesn't have any relevance to our population because the genetic pool in our population is very different from theirs. So, here we don't even do PRA. We just do a single antigen so that we know what are the antibodies which are there. And if there are a lot of antibodies, either class 1 or class 2, we do a prospective cross match before we do a transplant. And regarding LVADs, you spoke about hardware. Hardware is no longer in the market. It's been removed from the market some years ago. So that is most of the times the LVAD used abroad will be the Berlin heart. Berlin heart can be it's a paracorporeal device that can be used in any body size, right from infants to adults. But we have that in the country, but there's been only one instance of that being used by Bala. It costs about 1 crore and 30 lakhs. So, and a lot of times you will probably need to replace it because of clotting. So, during the course of the disease, as a bridge to transplant, you might require several of them. So the amount of money required for that is so much that we would just use ECMO or CentriMax. You also said that there is no ex vivo perfusion system for the heart, which is not correct. There are ex vivo perfusion systems for the heart, and it is no longer called ex vivo systems. It is called ex situ systems because of this is the nomenclature what is going on now. Again, hemorrhage from suture lines is not a very common problem in heart transplant because by the time you're doing heart transplant, you would have known how to stitch without it bleeding. It's not like a beginner who is doing heart transplant usually. So we do not ever use aproteinin. Aproteinin is not even available anymore in the market. And you said in NH we use protamine. Oh, that statement is like really crazy because every open heart surgery you have to use protamine, right? Is there something which we don't use protamine in?
No,
Everywhere
sir.
we use protamine. So what is special about pediatric heart transplants and protamine? Everywhere we use it. And inotropic support, the go-to inotrope as recommended by the ISHLT is still dopamine and noradrenaline. See, it is important to maintain a decent diastolic pressure in a heart transplant patient, and milrinone tends to reduce the diastolic pressure. And if you have a low diastolic pressure, the RV perfusion doesn't become normal because there is a steal from the right coronary artery into the systemic circulation if the SVR is low. So we try and maintain a decent diastolic pressure when we are coming off bypass. Only then you can have a good RV perfusion. There are so many reasons for the RV to fail post-transplant. So you have to be very, very careful in looking after the right ventricle when you're doing that. So we do not really use milrinone. We would use dopamine and noradrenaline. And one specific thing about immunosuppression in children is that we try and withdraw steroids of the immunosuppression in children, particularly. In adults, we don't really withdraw, we just minimize it because steroids cause a lot of growth retardation in children. And you spoke about parasympathetic denervation causing low heart rate. It is it is not parasympathetic denervation that causes low heart rate. Parasympathetic denervation causes high heart rate. That stands to reason, isn't it? Sympathetic denervation is what causes low heart rate.
So
When
hard.
you're doing a when you're doing a heart transplant, you cause denervation of both sympathetic and parasympathetic. So you end up getting a heart rate of around 90 or something like that eventually. And they're not responsive to many of the medications like atropine and other things. And it takes time for the heart rate to pick up in response to exertion or requirement of increase in heart rate. Anyway, the physiology of a transplanted heart is very different from this. Another error which you said is in primary graft dysfunction, you've listed hyperacute rejection as one of the causes. In primary graft dysfunction, you must exclude hyperacute rejection as a cause to call it primary graft dysfunction. The hyperacute rejection would be a cause of secondary heart dysfunction, not primary graft dysfunction. And biopsy in long-term surveillance is largely being replaced by what is called as liquid biopsies, or now we do what is called as the cell-free DNA. So these are donor-derived cell-free DNA, which is derived from the organ that you've transplanted. It is applicable to any solid organ transplant. When there is graft damage, the donor-derived cell-free DNAs will be circulating freely in the blood, which can be measured by next generation sequencers. And based on the amount of donor-derived cell-free DNA, you can predict that they are going into rejection. And the rise in this donor-derived cell-free DNA precedes the clinical rejection by months. So it is a good way of picking up rejection even before it becomes clinically evident. And about angina, you said children do not have angina following transplant. Adults also don't have it. That's not a child-specific thing. Because of denervation, most of the times you do not have angina. That is why you need to do a surveillance angiogram for everybody to see if they're developing coronary artery disease. Yeah. You've said about NH, we look at T gradients. You see, when you interrogate a heart after transplant with TE, don't take everything for granted what they tell you. If they tell you there's a gradient somewhere, you should measure with a needle, because the way the original heart is and the way they interrogate the structure and a transplanted heart or lung for that matter, when they interrogate it, the angle may be different. And you will always find that there is turbulence and a very high gradient. But if you put a needle and measure the gradient, there's usually no gradient. If um, you have gradient at the pulmonary artery anastomosis, that should be measured. I mean, you must measure it at least in your initial years, because if you have a gradient on the pulmonary artery anastomosis, that puts an additional afterload on the RV. And as I said, there is enough reason for the RV to fail post transplant. A gradient will make that even worse. So you should not hesitate to redo anything where there is a gradient. But gradient, you must go by pressure measurement with a needle stick rather than echo based one. So echo might guide you if you want to measure or not. Yeah, I think that's probably what I wanted to say. But when you're talking about pediatric heart transplants, I would have wanted you to speak more about how the surgical techniques are designed for dealing with morphologically abnormal hearts, rather than these. As I said, these are articles written by non-surgeons, and one is just the source is from the data which is published by the ISHLT annually. Somebody's just analyzed the data and written an article. And the other group at least have seen some transplant. The first group, I don't think they've even seen a transplant.
So, Divyanshi, you realize that this is a highly specific and a specialized field, and you try to, what exactly is happening is that before understanding the basics of the whole the transplant and the management of the thing, you are trying before learning how to sit and stand, you are trying to run. That is the gist of the things. And as Julius very rightly pointed out, you must pick and choose articles which are relevant to us as surgeons. And I don't think you should be looking at journals other than annals, JTCVS, EJCTS, and seminars of cardiothoracic surgery and maybe thoracic surgical clinics. These are the only five journals that you should be looking at and see what is the trend that is going on in these because sometimes there will be same topics in different journals, so you know that this is the hot topic or the trend, and that which is practical, you must choose that sort of articles. And I also want to tell all of you that you cannot tell us what you're going to present the previous evening. Okay, anybody who's doing the journal club should take a permission or to take approval from Dr. Jairaj or me at least a week before. Don't talk some irrelevant topics and things like that. This is of not going to be of any use. Okay, we are doing pediatric heart transplants in NH and things like that, but that is not going to be of any use to you. One, to pass your exam. Second, you are not going to be doing a pediatric heart transplant soon after you qualify. It is a highly specialized thing which requires a lot of training and experience. So sometimes these topics become irrelevant. Okay. Sir, you have anything to say?
No, I got only general comments actually. The thing is that the pediatric heart transplant is highly technical job actually. Surgeon who does that must be excellent in transplant and also very excellent in pediatric cardiac surgery. And also something about the history. You all know that Christian Barnard did the first transplant on December 3, 1967. And I read in that article, within 3 days, Adrian Kantrowitz did a heart transplant in a 19-day-old child. Do you know what is the other contribution of Adrian Kantrowitz?
Pardon, sir.
What is the major contribution to cardiac surgery by Adrian Kantrowitz other than pediatric, other than this transplant? He did only this one transplant. He never repeated that.
Yeah. And after that, they said next transplant was after 18 years.
Yeah, 20 years or
What is
so.
he well known for?
Kantrovich's name is very, very famous.
I've had the pleasure of meeting his family, not him. Though.
He's the father of IABP.
IABP.
You know that actually.
He's the one who developed the counter pulsation technique.
The other thing is I read the pediatric heart transplant forms about 14% of all cardiac transplantations. I said it should be a very good pediatric cardiac surgeon, cardiac surgeon, because of the variation in systemic veins. Either the donor or the recipient has got a left superior vena cava. I've discussed this once with Julius, or pulmonary venous abnormalities may be there. So, so all these things you may be able to tackle on the table actually.
We
Then
recently we did one who had a TAPVC, uncorrected TAPVC.
that you should know. The other thing is, the main indications are actually congenital heart disease, and also I said cardiomyopathy in children. And cardiomyopathy, the heart transplant has got a better result. But I miss in the thing, ISHLT heart transplant results in different groups, the 11 to 17, how they survive, the newborn, first year, the survival, it's all given in those things. So
Yeah.
that would be that. The most important thing is that the availability of donor and the waiting time is extremely high in cases of children because of the lack of availability of a donor in such cases. So I don't know, the can be after cerebral death or also after circulatory death. Some cases, when a patient is the circulatory death. I think especially from St. Vincent's, they started this thing. And a patient who's being resuscitated when you can't do that. Whether such art can be harvested to increase the availability of a donor heart, actually.
Yeah, I think one of the important ways of getting around that was what Laurie West came up with to do ABO incompatible transplants.
Yeah.
So, any group can be put into anybody kind of thing. See, uh, I when you are born, you don't have antibodies against the other blood groups. That is something which you acquire, as in these antibodies are formed against bacteria that are in the gut. So it takes somewhere between 6 months to 1 year for you to form isohemagglutinins. So before 6 months, ABO incompatible is not very difficult. It can be done in like kidney, they do regularly for ABO incompatible ones. So similarly, with the use of some filters, we can remove these isohemagglutinins and use rituximab and other things to reduce the further production of these antibodies. So it can be done, but I think I know Bala has done one, but that patient did not survive. Uh, in adults, I don't think it's a bright idea to do ABO incompatible heart transplants, but infants, it's really not a big issue.
The other thing is, these days, most of the cardiac transplant patient comes with a mechanical circulatory access device. But I don't know in children. I
Yeah.
read that if they below 20 kilograms or the body surface area is more than less than 1.2 meters square, it's very difficult. Is it to put a mechanical circulatory arrest, Juliet? Is it?
It is very difficult to use the durable devices for children, but there was a device being developed by Jarvik Heart for children specifically. That's an intraventricular device which is implanted. There was a trial called Pumpkin Trial, which included only children for Jarvik, but that really never came into mass production. So we don't have a durable device for children. So generally ECMO or a Centrimag kind of VAD or a paracorporeal devices are the way to go for bridging children. We've done some. We've done ECMO converted to BiVAD and then transplanted.
In children.
Yeah, in children. Yes.
The other thing, you said indications, but I've extended some more, because a patient born with a hypoplastic left heart syndrome, you cannot do transplant immediately. They need a palliation of an Norwood one, or even then only you can. So most of the kids who come for uh, pediatric transplant for congenital heart disease, they might have had one or two palliative or even a definitive surgery, like a failing one time.
Yeah.
Many of those things are there, or a patient with coarctation who had a surgery earlier. So most of the patients who come for pediatric cardiac transplant may have one or more operations, and it's a difficult access also. And in children, and very difficult to have a peripheral cannula to make your sternotomy safe also. So it's a very sophisticated, complicated procedure to do pediatric cardiac transplant than another other cardiac.
Yeah, one thing I learned the hard way was, when you have a large ASD,
Yes,
and when you're doing a redo, and if you injure the RA,
yes,
there was one case that happened to me. I thought, anyway, this heart's going in the bin, so I didn't really bother much. I just put a sucker inside the RA and went on to dissect the heart out. But at the end of the operation, this patient never woke up because because of the ASD, air was just being sucked into the left side. So when you have an injury to the atria, it's probably best to just cross clamp right away so that you don't have air embolism.
yeah.
And for anyone who is interested in a transplant in morphologically abnormal hearts, there is a YouTube video of a speech which I had done in one of the pediatric meetings, which is available. If someone's interested in that, you can look at it. That describes all the various anomalies and how to surgically deal with that.
The other indication may be a Epstein anomaly, growth score 4, because but the only problem is there's a space problem in such cases because the whole chest is occupied by the atria, and so it's
Yeah.
a difficult problem.
We've had one very interesting experience with an Epstein once. The first time I see the child was after a cardiac arrest. They've been massaging that child for he was about 16 years old. So they were massaging him for nearly half an hour or so when I first saw him. And they were getting decent output. There was an arterial line and all that. So I took him to theater to put him on ECMO without really knowing the anatomy or anything. We opened the chest and I was trying to do open cardiac massage and I was not getting any output. Whereas closed cardiac massage was getting excellent output, and that too by some girl anesthetist who was half my size. They were getting good output, and I am not able to get any output doing an open cardiac massage. And then I realized that I am only holding one corner. I was only holding one corner of the heart with my hand. So then I put my two hands inside and started massaging like this. Then I got some output. So I without purse strings, I put two cannulas and went on ECMO. And this was what 7 8 years ago. That child is still alive.
Should have given some statistics from ISHLT about the survival of these things.
Yeah, yeah. All that is available. Very well analyzed statistics are available in terms of the groups and differential survival. And 1 year they really put a lot of effort into publishing results on size matching with the emphasis on predicted heart mass. But unfortunately, predicted heart mass is not applicable to children. So the PHM calculations are available only above 18. And I think Srikanth from our unit has published
Yes,
a
sir.
paper on
Donor heart match. Yes,
yeah,
sir.
size matching.
What I read in size matching is the ratio more than 2.5 or less than 0.5. Is
Yeah.
it something like that?
Yes, there is a sort of graph that goes like this. So the mortality goes up above 1 in terms of odds ratio when it is below 0.7 and above 1.5.
Okay.
There are recorded ISHLT talks on pediatric heart transplants, which is available on the ISHLT site. See, you don't find many talks on surgical techniques in ISHLT, but all the other aspects you will find. There is one talk by Jonathan Chen. He was in Columbia Presbyterian at that time. He's done a good talk on morphologically abnormal hearts, which is available on the ISHLT conference site from 2016.
What was the rate complications like coronary arteriopathy and other things. There
Yeah,
is
I think
no
she mentioned that. She mentioned that.
You
But
you get accelerated coronary disease in the pediatric transplant.
no, in pediatrics, it's relatively lower because, and their mortality is all in the immediate post-op. Once
Okay.
you survive that period, they tend to have much better long-term outcomes. You do get, but not as much as adults. We don't really know all the causes for the coronary vasculopathy. The milieu for coronary vasculopathy apparently is set even at the time of brain death, with the amount of stress response the heart undergoes. So the milieu starts even at that point before the transplant, and for some reason it is very different in different individuals. Is it partly immunological, partly cholesterol and other atherosclerotic related things? So it's not so great in terms of understanding.
generally for the knowledge. You know that the great Walton Lehigh trained two cardiac surgeons, one Christian Barnard and Norman Shumway. And Christian Barnard, before even trying to get the rejection problem sorted out, went ahead in South Africa and did the first heart transplant in 1967, whereas Sambe was working on the rejection problem, and that problem was solved only in 1970, and the results improved after that.
I see there is a lot of if you look at the story of Christian Bernard and all of that, there is an American narrative which demonizes him a lot because they just didn't like the fact that somebody outside of America went and did the first heart transplant. So they have, I was listening to Jameson telling me these stories. Jameson and Kristen Barnard had worked together under Lily High at that time. So and Shamway was also there. They were all together. So what has happened is they keep telling that Christian Barnard didn't know anything about immunosuppression, and he came there to learn kidney transplant. So he went to South Africa after his training, and he was doing cardiac surgery with the pump which Lilihai had gifted him, and he was managing cardiac surgery quite well. He had excellent results from tetralogy and other operations, and then he decided to do transplant.
Marion Barnard was also a cardiac surgeon.
Yes, yes, yeah.
Yeah.
So he went to US to learn immunosuppression from the kidney transplant group. So he went and worked for a while in a kidney transplant hospital to learn immunosuppression. And at that time, he also went to Lower's lab. Richard Lower was doing animal experiments at that time.
Yeah.
So the perfusionist with Richard Lower was a South African. So he got access to see his animal experiments. See, Bernard has also been doing animal experiments prior to all of this. It was not like out of the blue, the Americans tried to say that he just went and did a heart transplant out of the blue because the laws were lax there and he could do it. So that is the narrative they've come up with. Actually, that is not true. He worked very hard on getting that done. And he learned immunosuppression. He went back to South Africa, did one kidney transplant. There is a quote from him saying that he must be the only surgeon in the world who's got excellent 100% long-term survival in kidney transplant because he did only one. And that patient survived longer than 10 years. So he wanted to test out his knowledge of immunosuppression on the kidney transplant patient. And then he did this. See, of course, that time the immunosuppression was a little more primitive. The thing that changed the outcomes in heart transplant and immunosuppression related issues is endomyocardial biopsy. That was brought out by Billingham. So Margaret Billingham was the person who came up with that idea. Surveillance biopsies is what made the difference in heart transplant survival, which came up only in the 80s. Of course, we had better drugs in the 80s. Cyclosporin was there, and other things were there. And I think when I was training, also we were still doing MMF clinical trials. So we were randomizing patients to azathioprine and MMF when I was training in transplant. So these are all more recent drugs. After, earlier we were not able to pick up rejection until it became clinically apparent with ventricular dysfunction. At that point, a lot of times you cannot do much about it. So endomyocardial biopsy started picking it up before it became clinically apparent from surveillance biopsies. Now the new liquid biopsies can pick it up even earlier. So we may have a big difference in the way this works because of the liquid biopsies. Liquid biopsies became very popular during COVID because nobody could come for surveillance biopsies. So now it is sort of even we reduce the number of biopsies we do. We do this cell-free DNA first, and if the cell-free DNA shows a spike, then we biopsy.
Liquid biopsies come a big way in cancer, and
Yes.
especially detecting metastasis.
Yes.
So it has become a big field, so that people can, without doing any invasive biopsy techniques, liquid biopsy can detect metastasis much quicker and much easier. This happens especially with lung cancers and metastasis in the lungs from various other organs. So liquid biopsy is
it also makes sense to do liquid biopsies. Like, so for example, if you're doing a transplant kidney biopsy, we are going to pick up a few nephrons from somewhere that may or may not represent the whole kidney. But if you were to measure something out of the urine, that represents every single nephron in the kidney.
True.
Similarly, in the heart, if you're going to do an endomyocardial biopsy, you might be sampling a place where there is no inflammation or rejection. Or you may be sampling a place where you biopsied earlier and there is fibrosis. So there is, it's a blind procedure, and there is a lot of sampling error which can happen. But liquid biopsies make a lot more sense because it represents the whole organ rather than one bit of the organ.
And it's circulating throughout the body. So
yeah.
So the DNA is picked up from any peripheral site. Okay.
Okay, thank you very much.
Thanks, Julius, for all your comments. And
Sri Krishna and I have been telling these boys and girls to get at least somebody who's expert, so that, the knowledge can be given to everybody, Very good. Thanks.
The one few things that I wanted to tell you about these journal clubs is, first of all, pick up articles from a surgical journal. Second, from a reputed institute, whatever topic that you're talking about. And then also please look into the date of the article. Anything beyond 10 years is irrelevant in the present day and time. So these three things keep in mind, and then please get an approval either by Dr. Jairaj or myself at least a week before.
Yeah, I was telling you the same thing. If you wanted to speak of pediatric heart transplants, you should have spoken to me earlier. I would have given you enough material to. I have spent a ridiculously long time trying to understand pediatric heart transplants. I've got a lot of literature with me.
So if you had that much trouble, you can imagine what a third or fourth year CT resident would go through. They have to learn all the basics before they go on to these high-flown things. How many transplants have you seen, Divyanshi?
Sir, I observed 2.
Adult?
Yes, sir.
Okay, at least so you have an idea what's happening. Okay. Right, thank you. Thanks, everybody. Thank you, sir.
Thank you, sir.
Thank you.
Sorry, sir, for the inconvenience.